Nice. I have 12 o'clock noon, so we will go ahead and get started today. First, I'd like to thank Carolyn Miller with IRHA for supporting Zoom for us. She's done a great job while Allie has been out. Also want to thank Joyce Fillenworth and David Conrad at the State Office of Rural Health for supporting these education webinars for swing beds that we hope you find very educational. Our presenter today is Kerry Dunning, of course. She's been working with us the last couple of years on building swing bed programs and making sure that all of the critical access hospitals have all of the necessary information for compliance as well as quality improvement efforts and patient outcomes. So we're always glad to have Kerry share with us. We do want you to feel free to chat in and unmute your lines. If you hover at the bottom of your Zoom screen, you'll see a chat icon that you can click and open up chat, and also a mute microphone icon that you can click to mute and unmute yourself. We do encourage you to ask questions. Feel free to chime in at any time. Kerry is very open to that, as well as chat in questions, and we will make sure that things are addressed. I attached 2 PowerPoint presentations to the calendar invitation. Yesterday, I sent out the main slide deck that Kerry's going to start with today. And then she shared a handout with us this morning.
Nothing on it.
The handout is
okay. I need a venti iced Americano half decaf with Rissetto.
Mute some people there. Thank you. The additional handout was attached to the calendar invitation today too. When we send out the recording, I'll also make sure that both presentations are attached as well. We will be recording the session today and sending out that recording link. So please share with others. I know that it's really busy in all of the critical access hospitals. So feel free to share those recording links with those who have not attended. So Kerry, I'll go ahead and I will turn it over to you.
Thank you very much. I'm sorry to hear that Indiana is one of the states now battling another round of COVID, or at least an increase in COVID cases. I wish you all well and stay safe, please. We are going to talk about long haulers today, and this has been a surprising topic for me. I've been working on this for about 5 months for a variety of reasons, some of which we were beginning to see long haulers in some of my clients, both in their skilled facilities and their swing bed programs, and I'll describe what this means in a second. But I think it is an opportunity for swing beds. If nothing else, we need to be paying attention to it. So we're going to spend a little bit of time on that. And the second handout you're going to pull up, or I'm going to pull up for you on the screen, actually has some updates as CMS is updating some things. So I wanted to make sure that we hit those also. All right, so long haulers have an official name. It's a post-COVID-19 syndrome, PASC, or SARS-CoV-2. It is a syndrome. It is from people who have not fully recovered from COVID-19 in weeks or even months after they've had the first symptoms. So like everything else we have with COVID, there's no pattern to this. It's no pattern of what part of the body it hits or what system it hits. There's no pattern, particularly to age, though majority of the first full year of COVID have been more elderly or those who are infirmed with serious diseases with consequences every day in their life. What's going to be interesting about long haulers, you're going to see in a minute, it's hitting the younger group, that 30 to 40-year-old group primarily that we were seeing. And what's also interesting about long haulers is some of the studies are showing some results from a year ago, and I had not heard about this until about 2 months ago. So there was somebody out there researching and trying to figure out what was going on. So it can be people that are discharged and they go home and a week later they start feeling bad again, or 2 weeks later. The younger group, the average is about 3 to 4 months. So they finish up with their COVID symptoms, they go back to their life, and 3 to 4 months later they get hit hard And a lot of them have been respiratory patients, and we're seeing an increasing number of vestibular issues with that age group. So it's up to the individual. There is no way to say there's one way to look at this, one way to research this, one age group to pay attention to. And I will say this isn't unusual when we go back and look at post-infectious syndromes. And we can go back 80 years and find these syndromes. We certainly can go back to 2000 when we had the beginning of the SARS episodes in this country. Most of these symptoms are more commonly documented in women. And I will say this has been on my head forever, and I have no proof one way or the other, but women tend to self-report quicker than men. So I'm wondering if we have a disproportionate share of that right now going on. And then, as I said, the things that are going on are crossing all the systems. So long haulers, these are the typical symptoms. And several of these you will see hit that elderly group that we have more traditionally put in swing beds and certainly in skilled facilities. So the brain fog, increased memory loss, reduced attention, fatigue. If you go down a little bit, you'll see the dizziness and shortness of breath also have been signs for our more elderly coming in. And depression and anxiety hits all the age groups. So those are the symptoms. The increased risk, as I said, it's a significant list. And what's really not on there that we have seen in the last 2 months are the vestibular issues. So let me give you 2 quick examples. One, elderly, where I'm working with 5 hospital systems that own skilled facilities. And we started saying, has anybody noticed long haulers among your long-term care residents who had COVID? And at first, everybody said no. And I said, so have we looked at them closely? And everybody went back. And all 5 of these have somewhere between 95 and 100 beds in their nursing home. And all 5 found 1 or 2 residents that they have now identified as long haulers that they didn't notice initially, because in that older group, we're quick to assign reduced attention or memory loss or behavior issues or depression and anxiety with aging and with what has put them in the nursing home first. But the specific example I'm giving you that wasn't noticed initially, that has now been documented, was an individual who used to go down to eat meals, went to all the activities, was known to go out into the lobby and play 1 or 2 songs one-handed on the piano and that sort of thing. So very active. And she had COVID. She came back. She was interactive for a while. And then they noticed in the last 2 weeks, as we were doing this study, that she'd withdrawn to her room. And when they really studied it, she not only withdrawn to her room, she didn't want the light on anymore. There was documentation for that. She was sitting in a chair in the corner. So she had gone from a very, very active person to somebody wanting darkness, sitting in a chair. So they're now following her. The younger patient actually is an outpatient rehab in the facility and is a hospital employee who had COVID and went 3 months with nothing and all of a sudden couldn't stand up straight. So she's an outpatient therapy now with vestibular issues. She's actually an ER nurse. So somebody, again, that was very active and very aware, self-aware of her health. And she's going to be in outpatient therapy for a while. So when we talk about long haulers, obviously, I'm trying to base some of this discussion on potential admissions for your swing beds. Certainly, those of you that work with skilled nursing facilities or your system has a SNF, you probably need to be aware of it for that. But I think this is now going to spread out into our outpatient therapy services because of this younger group. So the opportunity for skilled nursing is at the end of October, and I just looked at the number for the end of November, and it's over 730,000 now. So the total resident confirmed COVID cases are still going up. And as we go through this, Becky and I were talking before we got on formally, the New England states, 3 of them, I think 4 now, have already declared emergencies and have National Guard medics working with them because of the increased cases. Becky shared that you have 5 or 6 states there in the Midwest, upper Midwest too, that are going through another round of COVID admissions. So we're going to see this number just keep going up, I think, for a bit. So these are patients that couldn't return to a SNF or assisted living or even to home initially. The other thing I kind of mentioned there is Mayo Clinic's beginning to study this, and they feel like some of the effects for this elderly population can last more than a year. So that's the long hauler discussion. One of the interesting things on why I think this is important is how fast groups are moving to address it. So palliative care hospice organizations are already working with CMS and the CDC, CMS and CDC to declare, sort of what are the symptoms and signs and symptoms of this, and then they're beginning to work with, can we get Medicaid coverage for those? I'm sure everybody's aware, but I don't take it for granted. The difference between palliative care and hospice is the palliative care does not have to have a terminal diagnosis. That's why this long hauler syndrome will probably fit more, quote, neatly, end quote, into palliative care regulations as we go forward. So the best practices that you can work with now are to help your long-term care facilities and skilled facilities in your market area start asking these questions. Are we addressing at-risk populations within those nursing homes? You can go as far as education, vaccine availability, all those things that you're probably already doing. But this additional question is if they are noticing patients that seem to either are returning to or are having continuing side effects that we might have tied back to the original COVID diagnosis. So our role then, as I said, is first to educate. I think it's research. I think it's really important that each of our rural communities get on top of this quickly and understand, as I just said, I only have 5. That's certainly not statistically strong, but of those 5, they all have 1 to 2 long haulers in those nursing homes between 95 and 100 beds. We need to know this. We need to be able to speak up for these patients. And as Washington and others start trying to do the research on this, I think it's going to be important that we can statistically show what percentages are going on in our rural areas. So COVID obviously was originally the older adults, those with chronic conditions. The skilled facilities have had higher mortality rates, which you've known. We are seeing significant ethnic and racial disparities across the country. And that goes along, for instance, with African Americans having a higher percentage of diabetes, for instance, and so they have chronic conditions from that, and that impacted them. I will also say with the disparities in rural areas, we also have racial disparities, ethnic disparities, and poverty levels that hit rural areas a lot harder. And so we may see some lines of this forming along some of those population bases. For those of you that have nurse navigators, all of you who have social workers, care management, doing transition of care type projects, this is where we probably need to get into that group and start having them ask what's going on in the community. So as I said, I originally wrote this towards the long-term care and skilled facilities. I think you probably will have a secondary population with the younger ones where we need to be working with the area groups that do outpatient therapy, PT mainly, but PT and OT and speech will probably be involved. For those returning hospital residents and coming back to your swing bed program, I would be double checking for this. And I do think we're going to have to address some social isolation factors, people that have gone home that really don't have somebody watching over them that we may have to do some follow-up with. Now, I'm providing one example that is urban. It is not rural, but CMS, as I said about a year ago, started recognizing some of this and funded a project that basically signed up mostly urban facilities. St. Barnabas is one of them. It's a hospital in New Jersey, if you want to look it up, their website. But they developed a care program, comprehensive assessment, recovery, and evaluation for these long haulers. And in 7 months, they're now, I think, in the 11th or 12th month, but I haven't seen the new data come from them yet. They have treated 120 patients. So it is not overly overwhelming right at this point. But I think we're underdiagnosing, underwatching, and then as more people have COVID, we're spreading out the risk to a larger group. So they have based it on an individualized care plan, all those things that you guys would be doing. what is really interesting, the reason I pointed this out as an example, their program has 17 specialties involved in it. That goes back to, this is not just vestibular, this is not just heart or whatever. Their specialties include behavioral health, cardiology, dentistry, dermatology, infectious diseases. You can read the list. It's extensive. And that is something that we're going to have to see, you know, who you partner with, what types of patients that you're seeing in your community. And that's why I'm suggesting that it might be behoove you to start talking with your nursing homes, start talking to your own staff, your PCPs, and let's see what's going on in your communities. The two most likely areas to deal with this, traditionally LTACs have taken the more chronically ill patients, and this is prior to COVID, so they did the severe pneumonias, double pneumonias, and people that were already compromised with other ill or other disease patterns. They did trachs. They obviously were the primary ones doing vents in this country and hemodialysis for a while. As you know, from even in your own state, skilled facilities, and I would say more importantly, skilled swing beds programs have been handling vent patients because of the COVID outbreak. So we're seeing a change in that. I know you're critical access, but I have been trying to teach you that learning what is on the MDS, which all the other facilities, skilled nursing facilities, and the rural hospital swing bed programs have to complete. It provides the definition for skill criteria. I hope you have a copy of that MDS. Becky, I think we've made it available, and we can certainly, if people don't have it, we'll get it out again. But if you look at section I, and I picked the respiratory diseases here because that seems to be with our elderly a common area for this, not only COVID, but the long hauler syndrome. And there's two categories there that are defined in the MDS for what they're looking for. What is really, really, really important, and I'm not doing enough of this today, we'll do it next month as the new year rolls around. It is critical that you get that primary diagnosis, not only in your documentation, but to the claim. And we'll talk more, as I said, next month about, we have hospital coders changing the code that you have documented, well documented in your swing bed documentation. I think because they're looking for what traditionally has come through the hospital instead of this is a skilled level of care. So I would suggest you get the MDS and start looking at the section I and the disease categories. There's 13 medical categories that CMS and obviously legislative results have defined as appropriate admissions to skilled care, and you need to be looking at that. For short term, the documentation is pretty straightforward, I think. There's nothing on there that should surprise you, but I did put a list there in case you want to go back and double check yourself. You may quickly add some other things to it as we go forward with that. All right, so with that in mind, then the second thing that we're going to look at today is really I can get it open, is an addition that I did yesterday and this morning, a little bit for long haulers, but we're at the time of the year where we have seen, can't talk and think, Becky, I'm in trouble. So where we have starting to see some of the changes that are going to be happening at the beginning of the year. And I'm trying to belay some of the questions I get from all of you, because we get these massive things from CMS that include the hospitals, that include skilled care, include swing beds, sort of in the past. And so a lot of you end up asking Becky, the state, and me questions of, does this particular piece of regulation coming out of CMS include swing beds or not? So I have been reading all of these for the last 4 weeks. My house is a mess. My tree isn't up. No, I'm joking. But anyway, it's something where I'm going to give you some heads up on a couple of things. So if people ask you, you have this in writing to begin with. So the first update has to do with an additional waiver added to our emergency declaration, which has been fairly rare. I don't know how I got that many days. I told you, Becky, I don't know how many days are in a month anymore, but that should be 1126. And this has to do with the dietary requirements. And they are waiving some of those requirements at this point because, as you see, I've put down here, and this is their language, but I put it in red, CMS is waiving the requirement due to the inability of individuals to enroll in, attend, or complete the certification program due to the circumstances related to COVID-19. So you probably need to let your dietary department know this, as well as whoever's over compliance in your facility. The OIG just posted in November a 44-page study on facility initiated discharges. I will tell you right away, this is directed at nursing homes. I have not seen any language in there for skilled, for swing bed programs, but I will say this is a warning, and we have been talking about it all year, that it isn't a matter of discharging patients. It is a matter of person-centered care. It's a matter of your IDT, your interdisciplinary team documentation being involved. It is a matter of the patient and or family members or patient representative having a say in the discharge and where people are going. So I think they're already saying they're going to start with state agencies, and they're going to start going through nursing homes and trying to figure out who is discharging inappropriately. And when you see the study, there are some that are just stunning that anybody is even doing that. So those were the extremes. What I would suggest for you is this is a review of your discharge process. How are you documenting that the patient and or patient family representative was involved? Is that in writing somewhere in your documentation? Is there a process that's being discussed in your IDT meeting? Is it documented there? It's just a double check because they could come in. State surveyors are coming into swing beds now, and they're going to have this on their mind because it's a mandate coming from OIG. And if you're not aware of OIG, it's the Office of Inspector General. And basically, they're the FBI for the federal government. They're the ones that do all the investigating of anything that is inappropriate in healthcare in any setting. There is a transmittal that was put out the end of November. I've given you the information there. It is something that all of us on the phone, I think about at least 99% of us on the phone will not have anything to do with, and that's how we certify providers and suppliers. But I've told you, and I mean it, I'm trying to read through anything because it had a highlight where they talked about SNF distinct parts, which were what made me stop and look at it. A swing bed is not a distinct part, but I wondered if they were going to group it all into one. And then there was this note, which was not in red in the document, but I've highlighted, note how this is different from swing bed units, which do not enroll separately and do not sign separate provider agreements. So your swing bed program will not be impacted by this, even if the rest of your hospital is. And again, some of these rules go back and forth, whether you are licensed as a critical access or as a rural hospital. So just want you to know that swing beds are not included, and that is the transmittal and the date in case it comes up in your facility. Another one that has just been updated, actually it was released earlier this year, but updated on November 22nd. This is where there's going to be a reduction in payment on the physician fee schedule for PTAs and what I call COTAs or OTAs on January 1. They're actually going to pay 85% of that fee schedule for any services provided by PTA and OTA. Then if you come down here in the rules, it says very, very clearly, this is for this payment, and then it says very clearly, with the exception of critical access hospitals and other providers that are not paid under the fee schedule, physician fee schedule rates. So you are excluded from this. So that doesn't mean you're outpatient. I don't know how that's going to impact your outpatient rehab. Somebody's going to have to figure out those rules. But your swing bed, and if you have a CORF, which very few of us anymore have a CORF, would be removed from that regulation too. There are some updates that you can look up if you are interested. I put the website here for vaccination rates, and it's got a lot of other information. And the main thing is it has a lot of nursing home data, and that may help you working with your nursing homes, understanding what's getting reported from them. So that's the resource there. And if you have not heard, good, my computer's telling me to do something. If you have not heard, Joint Commission released some new patient safety goals effective January 1 of 2022. That is a list of the standards, it's the actual standards. So if you're paying attention to that, that may be something you want to look at also. As far as long haulers, there's been some updated information. As I said, it's beginning to grow in interest. So I have put some highlights here so you can go look things up if you need more data. WebMD is actually going through and listing. And remember, we were talking about the ways it was showing up. Do you see this dizziness in 47%? That's the vestibular issues that we're beginning to see in that younger population. I'm not sure when they updated this, but that is up. Headache would go with the dizziness also. So you see there is some disruption. That's one. Then there Mayo, and I put the Mayo, a place where you can go look at it, did a study. And this is where, again, who's having mild cases, and the majority, again, being women involved in that. But Mayo has some data out there now, as does Johns Hopkins. So there's some leading researchers. This one is pretty interesting to me because this actually was studied in 2020, which means they had some knowledge of some long haulers then, even though the data has really come out in the last 5 months, 6 months, I think. And I think this is the data that's coming from those original urban hospitals that CMS had identified to participate in a program. This was reported most recently on CBS News. And if you look at these colors here, so if you look at the gold, the green, and whatever that is, pinkish, fuchsia, that is the majority. And look at that age group. It is not what we have traditionally seen with our COVID patients who have been elderly, or as I said, very infirmed. In fact, when you go to try and find, you can find 6-year-olds on here, and you can find a little bit of 70-year-olds, but you can't see they're hidden. 80-year-olds are hidden in here somewhere. This number is going to change because of other symptoms. This was the beginning of some of the long haulers and some of the respiratory issues that were coming out. I picked this one in particular. If you look down here, this is from Indiana University study that was done. So I figured you'd like to see something from your backyard. This is a nice overlay of what CDC, which are the shaded areas sort of in pink on this, has recognized versus what Indiana did some research, and others, again, Johns Hopkins, Mayo, all the big systems are finding similar information, very few percentage point differences, where they're noticing the symptoms that are coming back after they've had their COVID exposure. So it doesn't matter what the original COVID hit was, whether it was respiratory or another part of the system. There is some commonality for the long haulers coming back with these types of symptoms. So that may be, again, something you not only want to watch and help your nursing homes watch. I think you need to be watching your swing bed admissions, and you probably need to be talking to your ED, and you probably need to be talking about hospital admissions and seeing if there's any potential of this falling through on this. As I also said, Johns Hopkins is doing a lot of research right now, and they're finding that the long hauler is not tied to a severe case of COVID. It can be tied to what we would have considered a mild case of COVID originally. The long term, as you know, long hauler long term is an innocuous description right now because we haven't had this disease but a couple of years. So we don't know what long haul means ultimately, which is why I think it's really, really important each of you in rural areas start looking for it and start paying attention to what's going on in your state. And then the only time that we've seen post-viral symptoms that really have been studied in the last 20 years from SARS, which again, the first cases of that in the US were in 2000, and the MERS data, which would have been from about a decade ago. So we have very limited data to go on with this. So Becky, I think that's a lot to take in. I'd be curious to see if people have seen things or if they are interested in looking more at it, or where they will be with some of these discussions.
Yeah, definitely add in chat some of your thoughts, or feel free to unmute your line and ask any questions. Kerry, as you were talking though, I did think about You have seen several of the admission criteria or the admission policies for several of our hospitals in Indiana, and you look at them across the country, I know. Are there very specific things that individuals should be going back and evaluating to maybe update, provide more clarification to, or add to as we think about the potential of caring for some of these long hauler individuals, or other symptoms or other chronic conditions and complex conditions that many of our critical access hospitals are starting to see in their swing bed areas?
And that's a great question. We've just started asking that question. The question at this point, Becky, is does our current nursing assessments in each of our facilities cover that? If I go back, are we asking these kind of questions on our current nursing assessment? That would be where I think I would start. And you're probably asking something similar to that. I mean, you're going to ask if somebody's coughing. You're going to know if they have diarrhea. I mean, there's some of those things that we would be catching on a nursing assessment. Headache, I don't know that we ask all the time. I'm not a nurse, so I will not say one way or the other. And even if we hear that somebody has a headache or has a sore throat, are we applying that to flu? Are we applying that to colds? You know, the colds that are going around in our area? Are we, what I think we're going to have to do is take this list and say, does this person have a COVID diagnosis? And if they do, and I'm going to, Becky, I'll have to send it to you because I don't have it in front of me. There is now a long hauler diagnosis code. That's how serious it's getting. So that just came out in the last 48 hours. So let me get that to you to add to the post package that goes out. So I think we're going to have to start with your nursing assessments, decide how much of this sort of information is on there. And you may want, I don't know if your current nursing assessments, for instance, have a box that say, have you had COVID-19? Were you positive for COVID-19? If not, I think that would be the first place I would look. And that could be an add-on to your nursing assessment. It doesn't have to be an entire assessment unto itself yet. I don't think we know enough about it yet. And then the second part would be what symptoms they're presenting with, and then your team being educated enough to start trying to figure out if this is a post-COVID syndrome, which again has an official name, which we're not using, PASC, or post-COVID-19 syndrome. That help?
Yeah, no, that helps tremendously.
I think that's a good question.
The other thing that I thought about too is definitely fatigue is the big symptom. Have other critical access hospitals implemented activities that kind of help supplement what physical therapists are doing with them to help them combat the fatigue or address the fatigue more effectively?
I haven't seen anything formally. We certainly, I've heard discussions in different pockets around the country. I have several programs, and I think it's good regardless of what caused the issue. I have several programs training CNAs or techs to be more aware when they're in the room with the patients of their ability to function and if they are fatigued, because they can either get a therapist in there or there's been some discussion about, are we going to add in part of our training, for instance, and CNAs and techs don't have a lot of spare time, but in nursing homes or swing bed programs, but can they do a few, hand-arm exercises sort of thing, with a patient just to see how strong they think they are, not because they should be judging it, but because if they have concerns about it, they could then take it to nursing, and nursing could get, a PT eval or check it themselves or whatever is the process in the facility. But I think we're going to have to make those that are in contact with patients all the time more aware of these type of symptoms to be watching for.
I also appreciate you pointing out addressing the social isolation factors. I think that's definitely an issue that maybe hasn't been given quite enough attention. And I can even see that happening with swing bed patients as hospitals are challenged with, visitations that are allowed, a number of individuals that are allowed in hospitals. Any guidance there for our swing bed patients so that we don't add to any social isolation factors that become an issue for them?
Well, we've obviously been through a major round of COVID, and we've realized, the stories from across the country of, patients being taken to windows to see family members. It's just been heartbreaking. Social isolation is going to be a huge problem. And I'm just going to use myself as the first example. I was homebound for 14 months. I could still work from home because of Zoom and phone calls and all sorts of things. But I went 14 months without a hug, without a family member, in my house and that sort of thing. And you talk about elderly who are already isolated. In other words, they aren't working. They, live alone, or they live with an elderly spouse. They're not seeing people. So they're going to be coming in with, an orthopedic issue, or they're going to be coming in because they have the flu, or they're going to be coming in for all sorts of reasons. And we really, really need to be figuring out how isolated they have been and what we can do to recognize that and help them get some assistance. And if nothing else, getting people to call them. I know one of the most successful programs I ever set up, and it's still going on. I've talked about it a little bit. It was in Memphis for sickle cell patients. It was downtown Memphis, primarily an African-American population. And what we found were that people were isolated, and the churches in that area took it on and started making daily phone calls. And this is a metropolitan area. Now, it was limited to, I don't remember, 15 city blocks, but it was still, a major project for the churches to set it up. And 10 years later, that project's still going. The churches still call. So it may be something where we need to involve our community resources. And I don't think we can ask discharge planners to make daily calls. We have trouble getting the calls done that we need to have done from our standpoint. But maybe this is something where we can do some education in the community and talk about COVID by itself has increased social isolation, elderly, and the growing number of elderly infirmed people are going through social isolation. And then this disease by itself, when you look at some of this list here, causes some isolation. So I think it's a good project to look at, help from the community on, and educate them in the process. It's a good point, Becky.
And definitely feel free to unmute or chat in any questions you have. But the one last question I have is, many of our critical access hospitals are having more inpatients than they've had in a while, again, with this last surge, and less swing bed patients. However,
Correct.
over time, that is going to shift. So what recommendations do you have to make sure that we're ready for that shift, or any other words of wisdom that you can share during this time for us?
Well, I'm going to assume that all of you went through some variation of that with that first wave, where we got overrun with hospital admissions. And what was interesting is some of you shut down your swing bed programs during that. I mean, some of you, I'm saying the global, I don't know how many in Indiana specifically did, because they needed all the beds for acute patients. Others actually, and I think you have critical access hospitals listening in that are in one of the two larger healthcare systems in Indiana. So in those cases, we had where the larger hospitals were taking acute patients, and then the swing bed patients were or skilled patients were being funneled down to the critical access swing bed program. So they had a way to use a whole system to be more elastic in where they were admitting people going forward. So there is no perfect way to do this, and there never has been. It's just when we're in a crunch like this, it comes and goes so quickly that we have to be prepared. And the bottom line, and this has nothing to do with money, this has to do with licensure and regulations, is you are an acute facility. and therefore the need of the acute patient should always be first. That again would be another reason why we need to be talking to our skilled facilities. I suspect if some of your facilities shut down admissions the first time around, because that ended up being more accidental than planned, they're not going to be so slow in shutting it down this time. Nursing homes took a phenomenal, horrible consequence in having COVID patients in their population. So I'd be talking to them now, because if they're going to shut down admissions and you're going to need acute beds, where are we going to put these patients? And that's a discussion we should always sort of have in the back of our mind as we go through probably now much of 2022 with some version of COVID.
Okay. We'll pause here and the last few minutes here, see what other questions you have.
I'd love to hear if any of you have already started seeing long haulers or thought about it or heard about it, or, you know, is this a new topic or?
This is Andrea at Bremen, and it isn't a new topic. We've been hearing about it probably starting last year, or the first part of this year, some long haulers, where they continue. At first, it was like they continued to test positive for like months and months.
Yeah.
And so we have heard about it. My feeling right now is we're if you look at our numbers, at the same peak as we were a year ago. And when this first started, the medical offices were closed, and we redeployed that staff. Our surgeries that required inpatient stays were being held off. And a lot of those who put off healthcare are now coming in worse shape than they were a year ago. But we haven't put any of that stuff on hold. And we're still operating. It kind of is like, I saw a picture the other day where there was like a house burning in the background, and people were just walking by like nothing was happening.
Yeah.
And that's what it kind of feels like. The house is burning down in the background, and everybody's going around about their business in the same way. The sporting events are happening, the Christmas parties are happening, the people are gathering, and it's like, whoa, we're not doing so good here.
Well, and as you know, it's different all over the place for a lot of different reasons. I just saw yesterday, for instance, where the NFL has been allowed by a court to enforce vaccinations for all the football players. The colleges haven't necessarily done that. So just as you said, we're in a sporting world, or we're in a Christmas season or another religious holiday season this time of year. Becky and I were talking for a few minutes earlier. The last surge that happened a couple of months ago, Jacksonville, Florida, which is where I live, was the hottest spot on the map. And I watched people still walking around with no mask. So obviously I sort of retreated into my own home, again, trying to stay out of that. From your standpoint, one, I think that underpinning can be stunning to all of us that have seen the consequences of what COVID can do. But in the reality, perhaps knowing where you are now and suspecting that it's going to be there for a couple of weeks at a minimum at this high point again, then that's, I think somebody needs to be talking to the nursing homes and figuring out if they're shutting down, because your issue is going to be, when do you run out of acute beds, and or when do you run out of staff to care for acute beds? I think we have National Guard deploying medics across the country now. New England's been hit hard, and your area's been hit hard. But you're going to have to look at your own area and your own places where you typically have been able to discharge patients, maybe even quicker than later, because those sources may be drying up quickly as they get nervous about the same things you're talking about.
For our systems, we were a little bit of a valve because we could take swing beds, right? My swing volume has decreased because I can't transfer anybody out of my emergency department. Everybody's on diversion. And so I'm getting more admissions, and therefore I have less beds that I can swing.
Yeah.
So higher acuity, and less swing beds to help relieve that pressure valve from anybody else to discharge to.
Yeah, and that's never, I mean, I haven't been through a pandemic of this size. Obviously, we've had epidemics and pandemics in this country since 2000. We've had one every year, not more, but nothing of this consequence. But in the past, we've had to really shut down swing bed programs, not purposely shut them down, but we didn't have swing bed available because of the acute need. But in those circumstances, because of the way those disease processes were acting, we really could use a lot of our nursing homes to take, some of the patients for us. With what happened last year with COVID, most of these nursing homes are going to be very reticent to take any admissions at some point if they haven't already shut down on you. And that means it is going to back up the system. So if you are in a hospital system, I think you have Indiana University and Ascension in Indiana. Is that correct, Becky?
Correct.
Those are the two large, yeah. Those
And-
systems are going to have multiple hospitals, and I think that's worth some coordinating between the hospitals to see if somebody can. I know I think in the last surge, several of the critical access hospitals in each of those systems became swing bed only because they took acute patients elsewhere. That's a system issue that's going to have to figure out where the staffing is and what the consequences of transportation are, all sorts of things that come into play there. But all I can tell you, I feel for you. It saddens me to watch us go through this again and again and again. I keep hoping that we've seen, the worst, and then it bops us again. So I think what you're seeing is fatigue, where people just can't really sit there and admit here it is again. They don't have the energy to do that. I said to somebody this week, I really did spend 14 months in my house, other than going to the doctor's office. I said, I can't go back into my house again. I said it out loud. Well, you know what? I can. Just the first reaction is, oh, please, please, please. I don't want to do this all over. I think every one of us, whether it's you, Andrea, and your crew, that's not only having to take care of your home, but you're seeing it. You're flooded, with these patients that are much more ill and much more complicated. And then, trying to deal with where we're going to take care of them. So all I can say is I feel for you. I would be working with your area resources and this may be our new emergency planning, honestly. We were supposed to update our emergency plans last year. These emergency plans aren't very flexible. They don't help us. The only parallel I can give you is not this year, knock on wood, thank God, but the 4 years prior to this year, we had a hurricane so large that it covered the entire state of Florida at one time, everywhere in Florida. We had nowhere to transfer our patients off the coast into safer places because the entire state was covered. I think we're beginning to see these massive events. So I would be talking to your hospital and your system about how are we going to be doing emergency planning going forward? What are we going to do when we have a bolus of patients? And nowhere to put them. And we're going to have to get creative. And I have no idea what that means yet. But I know in hurricanes and tornadoes and fires, our natural disasters, we start setting up gyms and school systems and, that sort of thing to be our overflow. And that may be something you have to do in your area going forward. So that at least let you know that I'm empathetic to you. I don't have the golden answer.
Okay. Well, we're actually a little over on time today, but please feel free to reach out. I hope that today's information gave you the information you needed to begin to think about the future, think about planning, and maybe a few ways of dealing with the current situation. So we'll send out the recording link to everyone. If you'd like to forward that on, please feel free to do so. And we'll also, Kerry will send me the diagnosis code for long hauler. We'll also send out the link to the MDS to make sure that you do have the most recent version available. So take care, stay safe, and really appreciate you joining today. Thank you. Bye-bye.